Welcome, everyone. I'm Terri Likowski. I'm the US2 Program Director from US2. US2 has over 200 support groups throughout the U.S. and internationally. I know we've got a few hundred folks listening in tonight from all over the country. We're really, really excited about that. This is actually our third live webcast this year. Tonight, I'm really excited to be here in beautiful San Antonio, Texas. We've got a full house with us tonight. We're really proud that my support group leaders here in San Antonio packed the room, so thank you all so much for that. So it's my pleasure to introduce one of our group leaders here from San Antonio, Mr. Johnny Staha.
Thank you, Terri. Appreciate that. And welcome, everyone. So now we're live. So we would like to introduce to you at this time Chuck Strand. He is the man from Chicago. He's our chief, so he's my boss. So Chuck, come on out here. I kind of gave it away a while ago, and when I asked you about us, but thank you very much.
Thank you, Johnny. Thanks so much for all you do, and for everyone else that's a co-leader of different groups here in San Antonio for the support groups. All that you do is very much appreciated, because it's obviously not an easy task to come up with speakers every month for the support group meetings and find venues and rally all the folks around to attend the meetings. So all that you do in terms of your commitment and the energy and all that you put forth on an ongoing basis is so important. So we definitely thank you very much for all you do, and we thanks all of you for being here tonight. So I'd like to welcome all of you to this panel discussion and the webcast on advancing prostate cancer. And as Johnny mentioned, I'm Chuck Strand, CEO of US2 International. It's a nonprofit that's focused on providing educational resources and support services to the prostate cancer community at no charge. And we'd like to thank our sponsors. We'd like to thank Bayer for their support as a presenting sponsor of this event, in addition to sponsors Dendreon and Janssen Oncology, along with in-kind sponsorship from Los Padres. And we thank all of you for joining us tonight. It's those who are watching online through the webcast, and those of you who have traveled from the area surrounding San Antonio to be with us here in person tonight. For those of you who are watching this webcast online, we invite you to submit questions through the comments field at the bottom of your screen. We'll do our best to answer as many questions as possible during the webcast. And we'd also appreciate your feedback on the effectiveness of this panel discussion and webcast by completing the online post-event survey, which will be sent to all of you via email tomorrow. We're very pleased to be here to share important educational information specific to advancing prostate cancer through brief presentations from 3 physicians, followed by a panel discussion. And this evening's presentation will be moderated by Dr. Juan A. Reyna. Dr. Reyna finished his urology residency at the University of Texas Health Science San Antonio in 1981. And he was the first Mexican-American to have successfully completed this residency. He started his practice in San Antonio as a solo urologist that same year and grew the practice, Urology San Antonio, by merger and acquisition to become the largest urology practice in South Texas. There were 29 urologists and 1 radiation oncologist at Urology San Antonio when Dr. Reyna stepped down as president and CEO of the group in 2012. He is now staff urologist at Audie Murphy VA Hospital in San Antonio, is part of the clinic's faculty at UT Health. When Urology San Antonio renamed their cancer center to Reyna Cancer Center in 2012, Dr. Reyna and his wife, Joni, started a charitable organization dedicated to prostate cancer awareness in memory of their fathers. They appropriately named the organization Los Padres. Please join me now in welcoming Dr. Reyna.
Well, thank you very much for allowing me to be here. This is really a great honor. I think I'm one of the few people in San Antonio that has had the privilege speaking to all 3 US2 groups here in the city. Really a fabulous organization. Us two provide so much in the way of support to people that have prostate cancer in all levels of the disease. So one of the things that I was asked to do was kind of put together a group of speakers that could speak to this whole idea of advancing prostate cancer. I had the opportunity to think about the right way to do this. And in San Antonio, we have three major groups that provide care to prostate cancer patients. They are the private practice sector in San Antonio, which obviously is enormous. And there is the UT Health Science Center, which also provides a huge level of care, both throughout the city and at the VA hospital and the University Hospital. And lastly, the Department of Defense, who is very active in treating prostate cancer as well. And so we have a representative from each group tonight, and I think you'll find that the information is going to be very worthwhile for you to hear, and I'll tell you a little bit about these guys. Dr. Edwin Morales is a staff urologist at STAMC and has been somebody who I think we've known very well through our training program because he finished here. And then Dr. Vijay Gunuganti, who is not yet here, but I'm hoping he'll be here very shortly, is also representing the city as a medical oncologist. He's very involved in prostate cancer as well. And lastly, Dr. Michael Liss from the University of Texas Health Science Center in the Department of Urology will be our third faculty member. So I'm going to just give you a quick overview of what each guy is going to talk about. Eddie's going to talk about the kind of standard definitions for advancing prostate cancer. And he also is going to talk about what we call the stratification of risk. Who are the guys at a riskier level of their prostate cancer? And when they get to that level, what are the drugs or what are the treatments that we can use for these individuals? He's going to talk a little bit about the timing of these medications and how we learn to sequence and how we decide to sequence the medication, what comes after what. And that's a pretty important process. And lastly, prostate cancer has what we know as a classical life history and natural history, and he'll kind of address that natural history and how all these treatments fit into that concept. So Dr. Vijay Gunuganti is, again, a local oncologist, excuse me. He's going to talk a little bit more about the demographics of prostate cancer and where it stands as opposed to some of the other cancers that affect men in this country. He will also address the issue of current treatments, but Vijay is going to kind of lean into the idea of what these treatments do, how they work, and what are the potential side effects of these treatments. What could go wrong? What are the things you have to be aware of as you enlist yourself into the idea of treating prostate cancer? He will also speak to the idea of radiation in the treatment of prostate cancer, not before these cancers have advanced, but after these cancers have advanced. And lastly, where chemotherapy is involved, what place does it have in the treatment of prostate cancer? Our third speaker will be Michael Liss, and he's going to talk about where is prostate going in the future, what is going on right now, what is happening in labs and the major centers in the country that are exciting for us, that have a place, will have a potential place for the treatment of prostate cancer. He'll also talk about genomics and what the basis for all the multiple agents that we are using and treatments and diagnostic tools and where genomics fit into that. He will talk about imaging and the idea of using MRI, a rather new radionuclide called Oxumin, which is really helping us define where these cancers are occurring when we can't seem to figure out why the PSAs are still going up. And lastly, Michael will talk about surgery, although not real common in the advancing prostate cancer. There is a place for cytoreductive surgery, which is removing the prostate with the hopes of helping our other agents have a better effect on the patient. So with that, I'll go ahead and start. This is Eddie Morales. Nice tie, Eddie. He's a staff urologist, oncologist at SAMC. He's assistant professor of the Edwin Herbert School of Medicine of Uniform Stress Services and of the Health Science Center. He's a distinguished graduate of the United States Military Academy in West Point, and he's a graduate of University of Pennsylvania School of Medicine. He did his residency here at the UT Health Science Center, did a fellowship, part of it at the MD Anderson facility in Houston, came back and did another year here with us. And Eddie's a terrific urologist, oncologist, and a super surgeon. So I'll ask Eddie to come up and do his presentation.
Okay, well, when I was first approached for this talk, they wanted me to give a broad overview of advanced prostate cancer. So I'm going to constrain this talk to talk about advanced prostate cancer. And we're going to start because there's so many words thrown around. There's clinically localized prostate cancer. There's a locally advanced prostate cancer. There's metastatic prostate cancer. Then there's stages, stage 1, stage 2, stage 3, stage 4. There's biochemical recurrence. There's non-biochemical recurrence. There's castrate resistant. There's non-castrate resistant. There's so many words that in order for us to even talk about it, let's start with some definitions, okay? First, some disclosures, all right? Financial disclosures, I ain't got any, okay? I make a regular major salary at SAMC, so that's that. So let's talk, the first definition I want to go over is biochemical recurrence. This is the start of we're getting away from clinically localized prostate cancer that's had, by definition, a definitive treatment of some sort. That definitive treatment is either radical prostatectomy, either through an open or robotic approach. It can be external beam radiation therapy. It can be proton therapy, which is a fancy kind of external beam radiation therapy. It can be brachytherapy, any definitive treatment that's meant to treat the entire gland, okay? And that is defined separately because in radiation therapy, in prostate therapy, and brachytherapy with the radioactive implants, the prostate is left in situ. So, you know, as all of y'all are well aware, PSA is made by both benign and malignant prostate cells. So the definitions are different if you had your prostate radiated and yet it's still in your body versus a surgeon like myself cut it out. So for radiotherapy, what we look for is in the first year or two after radiation, there is a nadir. That is the lowest value of the PSA after definitive treatment with radiation. And their definition of recurrence, this is the ASTRO criteria, is 2 nanograms per deciliter above whatever that nadir is. So if you were 10, you went to 1. If you went to 3, outside, and we usually say this is not in the guidelines, but there's a phenomenon called PSA bounce, where in the first year or two after radiation, you will see fluctuations that are not recurrence in PSA, just as the gland is reorganizing, partially dying and scarring. We're talking, this is usually considered after that window and after hormone deprivation is also over. Usually people that are radiated will be on 6 months to 2 years of hormone therapy. So 2 nanograms above that nadir is what we consider biochemical recurrence if you've been radiated or had, if you've had surgery, theoretically, the PSA level should go to 0. The prostate gland is no longer in situ. So the definition that we use now is a PSA 0.4 nanograms or more at any time. This includes, and then by any other consecutive increase. So different definitions, but they both lead to the same category of disease following definitive treatment, biochemical recurrence, very important. Now let's talk about biochemical recurrence with varying degrees eventually is treated with some form of hormonal therapy, androgen deprivation. This is done through a variety of mechanisms. It used to be done with surgical castration, bilateral orchiectomy. That's somewhat disfiguring. Nowadays, most patients get a gonadotropin agonist or antagonist. These are chemicals that turn off the hypothalamus in the brain so that the testes are no longer getting the signal to manufacture testosterone. Common brands of these are Lupron, one of our sponsors today, Leuprolide, Degarelix, Firmagon. These are chemicals that inhibit the testicular production of testosterone via the brain, and they work very well. And androgen deprivation therapy works anywhere from 6 months to 1 year to, I've seen it work almost 20. We don't know why. At some point, the cancer cells figure out a way to get past this treatment. This treatment was so revolutionary, in a slide to follow, that the scientists who discovered it, who were urologists, won the Nobel Prize in medicine. Because you could take a patient that had metastatic disease, prostate cancer in his brain, in his lungs, in his bones. You could, this was in the 50s, you could surgically remove his testicles. They didn't have those drugs at the time, and the metastases would melt away within days. They would walk out of the hospital. They could come in paralyzed from a spinal cord mass and walk out. It was phenomenal. Unfortunately, as we learned later, eventually, almost invariably, the cancer comes back. So, when we have two categories for that cancer that has outsmarted our first-line therapy, our androgen deprivation therapy. We have non-metastatic, castrate-resistant prostate cancer. This is exactly what it sounds like. It's rising PSA in the setting of a castrate level of testosterone, okay? And we typically, this varies based on clinician, and I don't want to get in the weeds with what your urologist has done, what your geomedical oncologist has done, but typically anywhere around 2, I'm starting to think this is biochemical recurrence. Metastatic castrate-resistant prostate cancer is that entity A above, plus when I take a picture, when I stage you with a CT with a chest X-ray, I see evidence of metastatic disease. That is swollen lymph nodes, what's called lymphadenopathy, or metastases to the visceral organs, and of course for prostate cancer, most likely the bone. That is then further categorized as asymptomatic or symptomatic, meaning is the only evidence we have of metastasis some bumps on a CT scan, or is the patient experiencing pain, pathologic fractures of the long bones or spine would be symptomatic. One of the other subcategories of this in the guidelines is symptomatic is defined by usage of opioid narcotics for pain control, anything requiring sort of pain control. So what is the androgen receptor axis? Well, the androgen receptor axis is a nuclear hormone receptor called androgen receptor, or AR, that lives inside of our cells. It lives in both men and women, does different functions in both, but it's what makes us build muscle. It helps give us facial hair. It deepens our voice. But it also is the primary fuel for the differentiation and growth of prostate cancer cells. So there's several ways for us to intercept this axis. As I talked about here, the initial first line is either surgical castration, we remove the testicles, or we block at the hypothalamus level. We block the initial hormone signals that tell the testis to make testosterone. These are with Lupron, Firmagon, or even for a while, there may still be some people on low-dose estrogen, as well as surgical castration. The other organ in the body that makes testosterone in much smaller amounts are the adrenal glands. These are the fatty little glands that are paired on top of your kidneys in the back of your abdomen. These continue to make a low level of testosterone even when the testes are removed or are no longer making testosterone. Agents that block this are agents that block the pathway, the chemical pathway by which steroids are made. These are drugs like ketoconazole, which is an antifungal that inhibits that pathway, as well as Zytiga or Abiraterone, which is a second generation blocker of the steroid pathway, and several corticosteroids. Then over here, we have the other way to block is to block the androgen receptor itself. These are anti-androgens. These are molecules that are not testosterone that bind to the androgen receptor but don't activate it. And they block in various pathways. Without going too much into it, they occupy the site, they occupy the lock so the key testosterone can't go in. And there's various, and these range from things like Castrate and to the much newer generation therapeutics like Xtandi or Enzalutamide, which we'll talk about. So prostate requires this access to grow. Even when the testicles are removed, even when the testes aren't making testosterone, eventually prostate cancer, believe it or not, learns to make its own inside the cell. So it's not responsive to these other methods, as we talked above, blocking that access. Oh, sorry. So as I mentioned before, this is Nobel Prize winning stuff. Charles B. Huggins, who's a urologist and a professor of surgery at the University of Chicago, was awarded the Nobel Prize in Medicine for his work on this. And at the time, it was magical. There was no cancer that was around where you could do a very simple procedure and have this metastases melt away. A patient that was wheelchair bound would walk out nearly days later. It was just a fantastic phenomenon. So let's talk about our patient. Our patient may or may not be you. This is a patient that has now has a rising PSA and has been on ADT, on androgen deprivation therapy, for some amount of time. Some next steps your clinician may try is a tactic called combined androgen blockade. What we do is we keep you on your Lupron, and then we add one of those non-steroidal anti-androgens. One of these over here. We add flutamide, we add Castrate, we add Nalandron. So, and that's been shown to, again, cause a PSA decrease. We're treating a number here. At this point, there's no evidence of metastatic disease. This is happening at a low PSA level, and is just a tweak that we have found that can buy months or more time. Eventually, what happens is the prostate cancer begins to use that antagonist, that Castrate, that flutamide, as an agonist. It binds, and the prostate cancer is able to accept this, what's supposed to be a blocker, as an actual activator of the androgen receptor. So what do we do then? Well, then we take it away. We take the anti-androgen away. It's still on your Lupron or your other agonist or antagonist. This too can help to halt, for some amount of time that's very variable, and for reasons we don't fully understand, that PSA progression. Eventually, though, we get to the point where you are now a non-metastatic, castrate-resistant prostate cancer patient. So my PSA is rising. My doctor's already given me Castrate. It worked great for 6 months, and he took it away, and that worked great for another 6 months. Now my PSA is rising. I don't know where to go. Well, there's a lot of good news. There's a lot of excellent options that are available now in the recent past, starting about 5 to 7 years ago, that can help patients in this category, patients with non-metastatic and minimally symptomatic metastatic castrate-resistant prostate. Tons of options. And we're going to go over a few of them today. So let's talk about index patients. Everyone is different. Your doctor, your urologist, your GU medical oncologist will treat you what's best for you. So in order for us to have a discussion about what to do, it's useful for us to construct index patients. Index patients are patients that allow us, or a broad category of a kind of person that's only representative of a group of patients, not anyone in particular, that allows us to make treatment decisions, risk stratification, and educated treatment options. All right? So, and these are straight from, I particularly use the AUA guidelines. They're somewhat different than the NCCN guidelines. In the end, it's the same. It's taking care of the patient and prolonging life as long as possible. Index patient 1 is the asymptomatic, non-metastatic, castrate-resistant prostate cancer. This is the male who has no radiographic evidence of disease, has a rising PSA, has been on ADT continuously, has a castrate level of testosterone. When this is checked, that's less than 50 nanograms per deciliter, and has no symptoms, is going about doing his thing, doing fine. There's several options. The two AUA options, which I'll talk about today, are observation. These patients last a variable amount of time, index patient 1, in this sort of limbo state where they don't actually get metastasis. The PSA may stay or continue to rise slowly or continue to rise fast. Your doctor may look at something called a PSA doubling time at this point. If you have a fast doubling time, usually less than 10 months or so, he may opt for a different treatment, which we'll talk about. Or if you have a slow doubling time, he may just continue to watch you. Again, everyone is different. This is a broad category. There has not been a therapy in this category of patient that's been proven to alter survival. And because each therapy, even therapies that have very minimal side effects, have side effects, our guidelines as a professional organization is that the preferred option is observation. I can tell you that's a hard pill for most men to swallow. It would be for me. I'd want to do something. So let's talk about what those options are outside of the clinical trial. By the way, I endorse that how we make prostate cancer treatment better for everyone is by participating in research. So if you ever have the opportunity to participate in a clinical trial, please do. This is how we further the field, how we make new discoveries so that men like me, when it's my time, will have even better therapies than y'all had. Let's talk about index patient 2, which I think is important. This is the asymptomatic metastatic castrate-resistant prostate cancer patient. First option. These are the options. There is no, I'm not going to apply an order of merit to this. These are options as given. There is no one has compared them head to head, and as I'm sure my colleagues will talk about, no one knows the best way to do them. This one first, that one first, this one first, that one second, that one last. Nobody knows. So I'm just going to start. This is completely in the order in which I decided to talk to you about that. The first deprivation is Provenge. Provenge is a very exciting autologous T-cell vaccine. It is not a chemotherapy. It is not an androgen receptor axis drug. It is immunotherapy. What it means is it takes some of your prostate cancer cells, it takes some of your T cells from your blood, They take them to their lab. They expose them to what are known molecules that are on the surface of prostate cancer cells called antigens, and they prime those T cells to then attack those prostate cancer antigens when they infuse them back in your body sometime later. Provenge has been proven to prolong overall survival in the asymptomatic and minimally symptomatic metastatic castrate-resistant prostate cancer. To my knowledge, as we talked about, it seems like it would be the ideal one for index patient 1, and that's currently being studied, I believe, but that's not been given at this point. So that use would be off-label. That doesn't mean it's wrong, it's just off-label. It's one of the few treatments in that it doesn't really affect PSA. So it was found to prolong survival in this patient cohort by almost 4 to 6 months at that period, but it didn't really affect the PSA. It affects it through this other mechanism where, again, your own immune system is killing cancer cells. Let's talk about option 2, Xtandi. Xtandi is enzalutamide. It is the byproduct of what we call rational drug design, meaning scientists looked at the crystal shape of the androgen receptor and they designed a molecule to fit in more tightly than all the other previous anti-androgens, flutamide, Castrate. It's still an anti-androgen, but its affinity for that testosterone receptor is like 20 times more. So it cannot be displaced by testosterone. So what it does is, as you see here, it blocks the AR from going into the cell and activating genes. It blocks the cell. The androgen receptor is unable to change shape to where it can bind with DNA and start activating stuff in the prostate cancer cell. Very exciting therapy. Again, works through multiple pathways in the hormonal axis. Is taken once daily. It's four capsules. Has a very slight risk of seizure as the predominant black box warning, but otherwise very well tolerated. Again, no one knows the right order in how to do this, okay? So if your doctor did one thing, it doesn't mean it's wrong. There is no guidelines. These are equivalent. Let's talk about number 3, Zytiga. This is Abiraterone. This inhibits steroid formation in your body as a whole. It shuts it down. It must be given in combination with a steroid, prednisone, so that so your body can maintain physiologic functions. You need cortisol to survive. Importantly, it stops the prostate cancer cells that have developed the ability to manufacture their own testosterone. It works very well. These can be used in order, one after the other, one progression. The order is undefined, as I mentioned, and that's frustrating. Finally, one option, which may or may not be better with recent evidence, which I think my colleagues talk about, is standard chemotherapy, or taxane, like Taxotere. This is a systemic infusion of a cytotoxic chemotherapy that kills rapidly dividing cells. It has sort of traditional chemotherapy side effects, which I know he's going to talk about, and is given in an infusion center, but this may also prolong survival even when given at this early stage. Index patient 3 is now symptomatic. This patient has now developed bone metastases that hurt. In addition to the other 3 therapies, there's one great therapy in this line that's been proven to help these patients, and that is Exofigo, which I can't even say right. But it is actually a radionuclide. It is an isotope of radium that emits helium nuclei, alpha particles so this drug is taken up by the bone, and it emits these helium nuclei that destroy locally the prostate cancer metastasis, but don't affect bone. Alpha particles are stopped by skin or the calcium wall of the bone, so it doesn't affect other organs. Previous treatments were radioactive strontium or cesium, and they emit beta particles, which cause a lot of local destruction and can damage the bone marrow. So this is a great advance for patients with symptomatic bone metastasis, and it reduces the risk of fracture and skeletal related events when taken with Xgeva or any of the other bone strengthening agents we used. It's most active in the bone marrow. It does not affect visceral or brain metastasis for obvious reasons. So now we have the natural history of prostate cancer is changing. Prostate cancer patients are living long times, and now the question is not what to give, but in what order to give it. And I don't have an answer for you. And that research is currently ongoing. At these stages here, we have Provenge, as we talked about, in the asymptomatic or very minimally symptomatic metastatic prostate cancer setting, possibly in the asymptomatic setting. We have Xtandi and Zytiga in the same indications. Again, no order. And we have, once you have bone mets, Exofigo or Radium-223. Is there a right sequence? I don't know. Hormone therapy is a start, but the answers are changing and evolving. Things may move around. We may see taxanes move up. We may see Provenge move to the asymptomatic setting. We may see Xtandi and Zytiga expand their indications as things go on. There's a lot of options and a lot of things going on. It's an exciting time to be in the prostate cancer field. I'm very excited. I'm taking a couple seconds over my time. I apologize, but a little humor. I am a urologist, so I find it, we like a little humor every now and then. So thank you very much for your time.
Thank you, Eddie. So we're going to wait, guys, on questions till all 3 speakers are finished, and then we'll have plenty of time for a question and answer session. So our next speaker is Dr. Vijay Gunuganti. As I told before, Vijay is a medical oncologist here with Texas Oncology, and he got his degree in India, his medical degree at the Deccan College of Medical Sciences. Did a surgical internship. I knew I liked you for some reason. In Philadelphia, did a medical internship and residency at Marshallfield, Wisconsin. He's board certified in internal medicine and medical oncology, and he's also board certified in palliative care and hospice. So with that, Vijay, you're on, brother.
How is everybody doing? Can you hear me all? Very good. So my job today is to make sure I tell you like 2 or 3 things. What are the new things which we have found in the last few years, and how we are moving the field a little bit early on, use the medications which are approved for late stages, can we bring them on to the early stage and make the patients live longer? Okay? So my disclosures, I'm the many speaker bureaus. And so prostate cancer, if you look at the incidence, is very high. Today, I saw a new patient, 82-year-old, went with urinary obstructive symptoms, and the urologist conducted a laser TURP, resection of the prostate through the urethra, and we found a Gleason's 9 aggressive prostate cancer. So the risk of prostate cancer is 1 in 6. Breast cancer is 1 in 8. So as you can see, the other cancers here, as kidney cancer, I mainly treat prostate cancer, bladder cancer, and kidney cancer and testicular cancer in South Texas. These are all the people who got prostate cancer. Above got surgeries, radiation, some never got to any treatment because we didn't have much treatments at that time. 12 years ago, we didn't have anything after hormonal therapy, patient progressed on hormonal therapy. Here is a slide how we are changing the field of prostate cancer. It's a multidisciplinary team approach. The patient, most men see urologists for a long time. They have very good relationship with them. They become, some of them, friends. And then when the patient has hormone refractory or castrate resistant prostate cancer, you get to see medical oncologists. Now we are saying when the patient gets diagnosed with prostate cancer, make sure the patient sees all of these specialists, even though you may not follow them. Just see, keep them as an initial consultation and say, here's my radiation oncologist, here's my medical oncologist. I can go to them anytime as the disease in the course happens. Okay, and we have pain specialists, nurses. So as you have seen this graph many times, here we are trying to use the medications early on, trying to drag the chemotherapy towards the end and bring on non-chemotherapeutic options upfront and sooner in the life cycle of patient. So early metastatic prostate cancer, this is the major thing. As Dr. Morales has mentioned, we use androgen deprivation therapy because it's hormone sensitive. We got a hormone sensitive prostate cancer and becomes hormone refractory at some point. So first time we proved that using chemotherapy before makes sense and has improved survival. Using Zytiga before the patient gets hormone refractory or castrate resistant, that improves survival of the patients. And as you can see here, they took a lot of patients who are hormone sensitive, metastatic disease, and they put them on Lupron plus chemotherapy versus Lupron alone, and they have seen an improvement in survival of 13.6 months longer when we use chemotherapy along with Lupron in a hormone sensitive, when the PSA starts going up and you have cancer in the bones. So, and high volume disease, low volume disease, if the patient has too many bone mets at the time of diagnosis, they lived almost 17 months improvement in median. Some of them lived almost 5 years extra. And then we also proved that Zytiga, which is used at the end when hormone refractory cancer happens, we have moved that early on into hormone sensitive prostate cancer along with Lupron or Zoladex or Degaralex. Any of the hormone injections we use, we use when we combine that with Zytiga, you have seen an improvement survival. 33 months when you combine Lupron and Zytiga versus Lupron alone for 14 months. Okay? And also this another study done which has also showed a 37% improvement in survival when you combine Zytiga or Abiraterone with Lupron. Results of androgen removal. One of the main things I was asked by Dr. Reyna to talk about is the side effects of all these medications. So I'm going to cover side effects of one of the common things we use, and which Dr. Morales has mentioned, all the new medications. We're going to talk about what are the side effects, what is the patient going to pay a price. Results of androgen, as you all know, Androgen removal causes, hot flashes, weight gain, fatigue, cognitive, sometimes memory loss on a long-term basis. As sometimes Lupron, Zoladex, they work for 20 years. So you are depleting the testosterone. It's like a male menopause. So you reduce the testosterone, it has some effects. So once the patient becomes castrate-resistant metastatic prostate cancer, as seen here, there's no right sequence, as Dr. Morales has mentioned, but here are the medications we use. Here is the brand name and the compound name, Xtandi, Enzalutamide, Zytiga, Abiraterone. These two are pills. We never, until recently, we always had chemotherapy approved in 2004. Before 2004, we didn't have any of these medications. First thing was to approve was chemotherapy, and then came along Xtandi and Zytiga, which are oral pills, and Xofigo. Xofigo, we're going to talk more about the side effects and the use of it. And as you have seen in the earlier talk, it causes increased, Xtandi causes, or enzalutamide, increases the survival of patients with prostate cancer after chemotherapy. Now we proved also before chemotherapy. So almost 18.4 months versus 13.6 months with Xtandi. The major side effects, one of the side effects of this medication is seizures, but it's a very small number of patients get 0.6% of patients had seizures. And most of the time they got fatigue. Fatigue, 33% versus 29% with placebo. So any bad fatigue is 6% versus 7%. So not much, very small incidence of fatigue. Okay, it's Abiraterone. Abiraterone or Zytiga was also used in patients who are castrate-resistant prostate cancer. That also has shown to improve survival. Okay, it helped most of the endpoints. The Abiraterone or Zytiga helped decrease in PSA, time to bone progression, decrease in pain, and delay in use of chemotherapy or death. All the endpoints have improved with use of Zytiga or Abiraterone in patients with castrate-resistant prostate cancer. And now we are using Zytiga. We brought it a little bit forward as I showed you, and we can use it in the early stage so that you shrink the cancer way below. The key is to kill the cancer when it's small. Then it takes a long time for it to grow, right? When it is small quantity, you shrink it or you kill most cancer cells, then it takes a while for it to grow. So this is a bone scan which showing that there is a decrease in the uptake after treatment. 6 months of Zytiga, we see almost disappearance of the cancer in the bone. And next is the Xofigo. Xofigo, as we have seen in the earlier talk, Dr. Morales has explained nicely, 70% of the prostate cancer patient, the cancer spreads to bones. In other cancers, you can go to liver, lung, but eventually prostate cancer can spread to other parts of the body, but predominantly it spreads to bones, 70% of the time. 30% of the time in the pelvic lymph nodes, liver, lung can happen. So when it goes to bones predominantly, why not attack the cancer in the bones? That may make the patients live longer. That's where the Xofigo plays a role. So as we have seen, the alpha particles, they exactly go to the prostate cancer cell, and this alpha particle releases the radiation up to 10 cell diameters, whereas the prior therapies like Quadramet, they destroy a little bit more bone marrow because they're beta particles, they compromise the bone marrow. You want to kill the cancer in the bone, not the bone marrow, right? So this alpha particle is a very focused, attaches to the cancer cell and destroys the cancer cell in the bones without causing major damage to the bone marrow. Okay? It was studied in 921 patients who had castrate-resistant prostate cancer, predominantly to the bone, and they got Xofigo, which is radium-223, versus placebo. These are the patients where we used everything. There was nothing else to help them. Okay? Primary endpoint was how many patients would survive longer. So almost 15 months improvement in survival, almost 4 months improvement in survival compared to placebo. What are the side effects of Xofigo? We know that Xofigo works, And if anybody has cancer spread to the bones and they're hormone refractory, they should consider Xofigo. And major side effects again are bone marrow, right? 2% of the patients had pancytopenia, low blood counts, anemia, low platelets. Some patients did have, but the severe side effects are 1 to 2% range. Out of 921 patients, half of them got Xofigo, around 6 to 10 of them got bone marrow suppression. So very small percentage of patients get bone marrow suppression where you become anemic and low blood counts. 1 to 2% of them. Next is chemotherapy. We are trying to delay the chemotherapy use as long as possible towards the end. But we also proved that giving 6 cycles of chemotherapy when you got first diagnosed with prostate cancer, which is already spread to the bones, or a high-risk prostate cancer, use of chemotherapy has improved survival. Why does the chemotherapy work along with hormonal therapy? You have 2 clones of 2 types of cancers when you get diagnosed with prostate. One which listens to the hormones, where when you starve them for testosterone, the cancer gets killed. And other clone or other group of cells are already you have some hormone refractory where the cells are saying, I don't want to listen to the Lupron or anything, I'm going to keep growing. We need to suppress those as well. That's the one which is going to grow eventually and haunt us. That's the rationale for using chemotherapy up front. Now, we can use chemotherapy later on. These are the 2 medications, docetaxel and Jevtana. And these are the main chemotherapies we use. And we also use bisphosphonate, which is the bone health medications, like Xgeva or Zomera, we use to decrease the fractures in the bones. Side effects of chemotherapy. A lot of times people think about, oh my God, chemotherapy, I don't want to go there. I truly understand that because you already are tired with lack of estrogen and you already took all the medications we told you and you're more tired. But use of chemotherapy, this is what I tell my patients. 1/3 of the patients have side effects, 2/3 don't. 4 major side effects. Nausea, vomiting, we have very good medications. 10, 20 years ago, we can only control nausea, vomiting in 50% of patients. Now we can control nausea and vomiting in cancer patients on chemotherapy up to 90 to 95%. Fatigue is the one which we cannot control. It's temporary. After 3rd day after chemotherapy to 6th day, you feel tired and you start getting better. Another side effect is marrow suppression, like anemia, low white cells, putting you at risk of infections, low platelets, causing minor bleeds, and hair loss. Hair does come back once we stop the treatment. These are the 4 big side effects, okay? Now we know, do we know the sequence? These are all the stages of prostate cancer. There's no stage, there is staging, stage 1, stage 2, stage 3, stage 4, but in prostate cancer, these are the stages. Hormone sensitive, castrate resistant, asymptomatic without any cancer in the bones or the lymph nodes, and symptomatic, increase in the symptoms. So we have to use hormone therapy throughout your life. Even if as I told you, there's a group of cells which still listen to Luprons. That's why you have to continue Lupron for a long time, forever. We have not proved that stopping is beneficial. Stopping may be detrimental. That's why we don't want to stop Lupron. And the next is radium-223, which I discussed. And then even in asymptomatic, hormone-sensitive prostate cancer patient, we are using Zytiga and chemotherapy. And if in hormone refractory, we have this docetaxel. And we can use all these medications in the later stages of the cancer as well. Okay? And also we use supportive medications, denosumab, which is Xgeva, and these have shown to decrease the time for the fracture of the bone. Eventually, we don't want a fracture of the bone. That bone is made stronger by using Xgeva and Zomera. Okay. So I'm going to stop here, and we'll take the questions at the end. So.
Thank you, Vijay. So our next speaker is Dr. Michael Liss, and I have the privilege of working with Michael at the VA. He's a urologic oncologist, assistant professor at the University of Texas Health Science Center, and he's the Roger L. and Laura D. Zeller Charitable Foundation Chair in Urologic Oncology. Mike's also the Director of Clinical Research at the University Health System, also the Principal Investigator for SWOG, which is Southwest Oncology Group, Veterans Healthcare, Audie Murphy VA Hospital. Mike has a master's degree in clinical research from the University of California in San Diego and his MD degree from the Medical College of Wisconsin. Did his robotic fellowship in San Diego, and Mike does a lot of robotic surgeries for us at the VA. It's been a privilege to work with him. So Mike, why don't you come up?
Great, thanks everyone. So a little story. I kind of got into prostate cancer research. I was a resident. I got into urology. My grandma was actually a urologic nurse. She said she was the vasectomy queen. I don't want to know, but so she was kind of encouraging me in this field for a while. And subsequently, I went to my residency in California, and one day I get a phone call, and my grandfather had diagnosed with prostate cancer. And the next year, his brother got diagnosed, and my wife's grandfather got diagnosed. So then after that, we started going to the doctor's appointments, and you start trying to figure out what the options are. And I just felt like, man, more needs to be done in this area. So that's why I got pretty passionate about clinical trials and advancing the field. So I'll talk a little bit about what's been going on. And I have no conflicts of interest. So I'll talk a little bit about the genetics, some imaging, and then some upcoming clinical trials. So one thing I do want to talk about that none of the other speakers talked about was screening. Now, I know that a lot of men here have already had prostate cancer, but one of the first questions, at least from my question, was, well, when do I start screening? If I had family history, or what do you tell your family members of when they start to get screening? And in 2012, the U.S. Preventative Task Force came out with recommendation against PSA screening. So obviously this led to a lot of arguments and discussion regarding, well, why did this happen? And a lot of times, we did a lot of surgery or treatment maybe on low-grade prostate cancer that didn't need it, so they didn't really see a benefit in the big clinical trials, and that maybe we needed to be focusing on higher risk patients. So now this has come kind of full circle. The pendulum swung back a little bit because of people saying, well, I think at least this should be a discussion with you and your physician rather than someone just saying, well, you can't get prostate cancer screening. I think everybody in this room would agree that they caught it somehow. So I do think there's a role, and that they justified that ages 55 to 69 would be the prime age, but now this should be a discussion. So I do think it's important. And so the new National Comprehensive Cancer Guidelines starts talking a little bit, and I circled some things that were new. And one is something called shared decision making. It's a new buzzword in medicine, and it's essentially that you talk to your patient and you ask them, do you want to be screened for prostate cancer? Or the patient can bring it up, I want to be screened for prostate cancer, or you both decide, I don't want to be. But that should be a discussion that should be had. And then the age groups have always changed a lot, but what I really wanted to talk about was the PSA-based algorithms. So they're actually now kind of putting you in categories. If your PSA is really, really low, maybe you don't need to have it every single year. And if your PSA is higher, maybe you need to be more frequent. So, and the one at the bottom here is some genetic testing. So, people with family history, or maybe the family member had breast cancer and they got tested for this BRCA gene. It's called breast cancer. BR is breast, CA is for cancer. So breast cancer gene 1 and 2. So someone else in the family had genetic testing, and it was positive. Well, now what does that mean for the guy or the family member? So I'll talk a little bit more about that. So I want to talk about African American men as well. They're very high risk for prostate cancer, and then the second subgroup is men with a family history of prostate cancer, like myself. So maybe these gentlemen need to be screened at that 45 or earlier time frame. So I think it's important to know your family history. Guys should talk. That was a big problem before, is that men just didn't talk about it. No one said anything. So that's why it's great for these groups to kind of get everybody's opinion and be a little more open about talking about it. Women have been doing this way better than guys have been doing for a long time, but I'm glad that us two has kind of brought everybody together and start talking about this. So, my approach is a little bit more individualized. Everybody's different. Every PSA is different. Every situation is different. So this is kind of what I use when I talk about screening. I'll just do a little bit about it, so when you go home you can talk to your family members or friends about it. And essentially I use the Prostate Cancer Prevention Trial. It's developed here by Ian Thompson at the UTL Science Center. And we kind of use these smiley faces. So this is somebody who's got a PSA tested, maybe they have some other testing done, and they want to know should they have a prostate biopsy or not. The green face would be that it's unlikely that they have prostate cancer. Yellow would be a low-grade prostate cancer, something we could watch with active surveillance. And the red would be some high-risk prostate cancer, and that's what I'd want to find. So we would put your information in this, and it's online, myprostatecancerrisk.com. You can just put your own numbers in there. Race, age, PSA, family history, what your examination showed, and if you ever had a biopsy before. And what comes out is this. It's a little more easier to understand. So if there's a lot of green faces, that means, okay, there's an 88% chance the biopsy will be negative. What I'm really looking for is the red face. So that's the risk of high-grade cancer. If this gentleman only has 1% risk, doing a prostate biopsy is probably not necessary for that person. Versus this guy. And obviously that's a little different. There's a much higher risk for prostate cancer in that gentleman. So what's going to be changing over the next few years is this list is going to expand, and you can start to see some things over here. A percent-free PSA, are you taking a particular medication? We've added PCA3, that's another biomarker in the urine. They're going to start adding some genetic markers as well. So we're updating this continuously as we go along, so as these tests come out, you can put them in the calculator and get a different risk profile. So that's what's kind of new and coming for the diagnosis, at least. And hereditary prostate cancer is kind of the hot topic right now in prostate cancer. So if you've had Gleason 7 or higher prostate cancer, and there's other breast cancer, ovarian cancer, pancreatic cancer in the family, or like I said, another family member was positive for the BRCA test, maybe they should have the BRCA test as well, or some other genetic testing. Now I have to emphasize that I really recommend a genetic counselor involved before and after, because there are some intricacies of doing genetic testing that, just ordering the test and kind of trying to go through all the data yourself is a lot. So I really think that before and after you should meet with them. So there's other genetic mutations that people can be looking for. And really for prostate cancer, it's the age of onset. So if you had somebody in the family, under age 50 that had prostate cancer, and I've had gentlemen I've treated that were in their 30s. So that gentleman's family members should probably get tested for genetic mutations, because that's really, really young. And then aggressiveness, obviously if you're fine and then just one day had back pain and showed up and there was prostate cancer all over. So that person's family members may need to be informed of that. So don't keep it to yourself. These are the BRCA mutations. BRCA2 was the one that has a little bit more prostate cancer risk. BRCA1 we don't know much yet. So this is something that is coming along. Something else I want to talk about, because I'm talking about the research, is these genes are something called small nucleotide polymorphism. So these are little genes. So your DNA is in your body, and that's essentially the building blocks, or the roadmap, if you will, to how to build cells in your body. So everybody has little bits of variation. That's why some people have big ears. Some people have, their pinky finger's crooked or something like that, right? Everybody has a little bit of variation, and some of that variation can actually increase the risk of a certain type of cancer. So we're finding out that we're taking big data sets of men who have generously donated their tissue sample or some blood, and we can look at these variations in big populations and say, okay, this group of men have this variation and they may be at higher risk for cancers. So sometimes they don't mean anything, and these are the genes. So there could be a little change in one of the genes and not much happens, kind of like a house. So you could say this gene was the color brick of the house. Well, it's not going to change the house very much. It just looks a little different, red brick versus a white brick. But if you changed one and it said, oh, this one was for the whole plumbing system and now the house isn't built with a plumbing system, well, that's a big change. That's a problem. Everybody's got to use that house, right? So that's a huge difference in small variations and that's how important these little DNA strands are. So we did a study, and I've been working on this for some time, about, okay, well, if I do the genetic test, can we see differences? So this is the reference set, this is a low-risk group, and that for every amount of those variations, the risk of cancer goes up. So if you have all the risk factors or all those variations, you have a 26% chance higher than the normal person of getting prostate cancer. I think that guy should get screened at the 45 or sooner than other people. So these are some of the things that are coming along. And I did go to the US2 website. There's a really fantastic section, the genetics and genomic testing, just because I can't cover every single test that has come out. There's this has a really nice summary of some of those, and I know everybody's at different stages. For prostate, some are on active surveillance, some already had their prostate out, and there's different genetic tools that we can use for someone who's at different stages. So I wanted to talk a little bit about active surveillance because there's been a lot of movement in this area. And so two big issues for active surveillance. So what is active surveillance? Well, you've been diagnosed with a prostate cancer. They said it was a Gleason 6 or a slow-growing type of prostate cancer, and we want to follow it. So the big issue is, number one, can the 3 become a 4? Can it get worse over time? So that's one thing we worry about. And there are some testing. So one is, when I say germline testing, that just means your normal DNA. So your normal DNA can be tested, and then secondary is your tumor can be tested. So they could take the SNPs from the biopsy, send it to a lab, and say, you know what, this is behaving a little more aggressive than we think it's behaving. So that's what some of the newer genetic tests are doing. And so if you're leaning a little more towards the aggressive, maybe you would want to treat that rather than watch it, versus some that kind of give you confidence and like, okay, the gene doesn't look like it's aggressive, so we're confident about active surveillance. And the second is sampling error. So the needle's only really small, obviously, so you could miss a section. And this happens when we take some men that say, you know what, they said the C word, I don't really want to do active surveillance, I just want it taken out. So they have a prostatectomy. 30% of the time they said, oh, you know what, there was higher risk prostate cancer in there, we just didn't hit it on the biopsy. So this is a huge area right now to make sure that we're not missing things, and that's when I talk about the imaging section. I think that's really more to take care of that section. So the first part is where genetics comes in. Will this cancer be more aggressive? Is it behaving on the inside worse than it looks on the outside, like a wolf in sheep's clothing kind of thing? Or did we just miss it with the needle? So then, like I said, after prostatectomy, there are some like Decipher score that can be done after prostatectomy to say, should I get radiation therapy? Right now, we know that we have a big clinical trial that showed that if you have high-risk prostate cancer that's getting out of the prostate or it's getting into the seminal vesicles, that maybe that's a candidate for radiation therapy after surgery. But sometimes those aren't evident. And you wanted to see, would I be a candidate or not? This could be a genetic test that could help. And then metastatic prostate cancer. What therapy should I treat my tumor? We're working on now various tests that we can take the cancer cell from the blood and do various testing on it. We can do genetic tests on it. Sometimes we can grow them up and put different chemicals on them to see if they still grow or not. So those are actively going on in the lab. One of the things is the chemotherapy that was mentioned earlier, and PARP inhibitors. So these are new inhibitors that if we check your DNA and they have a lot of mutations in them, and that there's a lot of blueprint errors in that DNA, that actually you should maybe do chemotherapy rather than stay on the hormone therapy and try the other drugs. So these are things that are kind of slightly changing the location of where the sequence we said when should we use certain things. So this is kind of the big table. I can't read everything on here, but really what I wanted to show is that eventually what we're going to do is we're going to start labeling your tumor a group 1 or 2 or 3, and then if you go down these different pathways, this is androgen receptor, this is where Abiraterone and Enzalutamide were. Well, maybe you have a sonic hedgehog inhibitor, or there's some kind of SPOP mutation, different mutations, then you would go down a different pathway. This one is for immunotherapy. So this is the tumor. So we're going to start basing our decisions on, well, what's the tumor doing? Even if maybe we should be using a melanoma drug because the tumor's acting like that rather than the prostate drug that everybody gets, right? So this is what's coming. It's slow because we haven't tested all those things. We don't know if they work. So this is really new. It's not for everybody, and it's really, they've tried to do them before, and some of the tests have failed. So that's why the research is going this way. Can we identify the pathways or how the cells are trying to escape our normal treatments, and can we do a different treatment for them? And this is a little bit for imaging. This is one of my, also I do a lot of imaging research, and prostate MRI has really come of age in the past probably 2 or 3 years. Before, one of my bosses used to say, it just looks like a snowstorm over Iowa. You can't tell what's what in there. So this is the prostate right here, and this is the peripheral zone. That's the most likely area where prostate cancer would occur, and if you see a dark spot in here, it's more likely prostate cancer. But that's not the only reason to get it to find cancer. We can actually locate the tumors now and do biopsies on that specific area. It can guide us to the location of where it is. So someone like an active surveillance, if we felt like we missed it, right, we could get an MRI. It could show us, oh, actually the bump is on the very, very top. So typically this is where our biopsies go. But what if it's sitting up here and we totally missed it? This MRI could help us with those particular situations. Does every man need the MRI? Absolutely not. Especially if they had a really small prostate, probably a good idea that we got you most likely got it. But if you have a really big prostate, this may be very helpful. So MRI, there's kind of 3 different things, and I know it's too many words on here, but largely MRI works for the detection of really big tumors, and they're poorly differentiated, so the low-grade ones might not show up on the MRI. So just because you have a negative MRI doesn't mean there's no cancer there, okay? The detection of extracapsular extension, that means when the prostate's trying to get out of the capsule. I always kind of say the prostate has a plumb skin on it, and if cancer is trying to bulge out of there, prior to surgery, we might want to know that. Prior to radiation therapy, they might want to go a little wider on that side. So it can help in our staging of men, where before all we had was our rectal examination and the PSA, essentially. So now we can kind of get a better idea of treatment planning. And then the pelvic lymph nodes. Now we can use MRI for staging of the pelvic lymph nodes. So now I typically, instead of ordering the CT scan, I'll do, which is still a good test to look for lymph nodes, but if I'm going to stage the prostate, I'll just get the lymph nodes as well with the MRI. So those are kind of the new things. So now some of the research that's going on, or remember I told you that we missed, there's a lot of times actually we see a lesion there, we biopsy it, and they're like, yeah, it was negative. We're like, well, we just had this whole discussion about how there was a spot there and we were going to biopsy it. Well, like I said, the MRI is not as good as we think it is. So there are some new techniques that we're doing, that we're using the water actually that's inside all our cells to enhance. So if there's more tissue in one spot, we can enhance it using just software imaging. That's where our engineers come in, and they're helping us design better MRI. Some of the new PET scans that are coming out, the C11 choline PET's been out for a little while, so that's a CT scan, and they give you a specific molecule of choline, and choline's used in rapidly dividing cells, so it can help us kind of diagnose a little bit sooner maybe a metastasis like this here. A newer one is the Oxumin test, so it's essentially so leucine is just one of those building blocks of that DNA I talked about. So They use that, so if you're making a lot of cells, you're using a lot of building blocks, so this can help that. So in the biochemical recurrence, gentlemen, where the PSA was rising and we did all the tests and we can't find it. We have no idea where it is. These are some of the tests that are going to start helping us see where those little tumors are. Can we do radiation to that spot? Should we start a treatment sooner? We don't know any of those answers. Actually, we don't know if diagnosing it earlier will actually help the outcome. We don't know that. So that's why the clinical trials are important. The last one was the PSMA PET. There's only a couple centers in the country that are trying this out. It's another little, very specific for prostate, very, very expensive. And like I said, we don't know if finding that little spot is going to help us in the long run or not yet. It makes sense that it would, but we don't know. So then some what I call oligometastatic disease. So that's the person who has maybe a couple of lymph nodes. They're diagnosed with prostate cancer. It's aggressive, and there's 1 or 2 lymph nodes that are in the pelvis. What can we do for that? A lot of times they say, well, there's nothing we can do. We just put you on hormone therapy. So we're kind of going back to the drawing board a little bit. Ovarian cancer, breast cancer, brain cancer, colon cancer, and renal cancer have all shown that just despite you have a little bit of tumor, if you take the bulk of the tumor out, and then the rest of your therapies may work a little better because it doesn't have as much cancer to fight, and your immune system can maybe target this area a little bit better without so much being there. So in radiation therapy, there's one going on in England. There's a couple starting here in the US as well. And for prostate, that's for when they show up, they have a lymph node, and we still remove the prostate. In the old days, when you opened the abdomen and you saw a lot of lymph nodes, you just stopped and closed back up. That was it. But now we know that in some of the clinical trials, when they did remove the prostate, that those patients live longer. So getting a lot of the cancer out in the initial stages might be helpful. So in summary, I talked a little bit about the genetics and the importance of screening in high-risk gentlemen that may want to tell their families about that. Imaging, so MRIs come a long way. It's helping with our staging, get a better look on the inside of the prostate, maybe help with planning different techniques. And then some of the new PET scans that are coming along to help us diagnose things earlier. And then on the horizon, the surgical and radiation clinical trials to help us control the cancer and maybe stop it from spreading so much. Thank you.
Thank you, Dr. Liss. So we're going to move on now to kind of a question and answer session. The panelists will be available to answer questions from the audience here, or we already have some questions lined up from our streaming that we've been doing through this talk. I want to thank the guys who are, I think, doing stellar presentations, really good stuff, I think, to help us understand this disease. It's a very complex disease, and just about the time we think we know what's going on, it comes back and slaps us on the head and tells us we don't. That doesn't stop us from trying, and I think some of the things that are going on with prostate cancer are really very exciting. So, where are you?
I'm right here with the microphone. If we have questions in the audience, please raise your hand. I'll bring the microphone over to you so you can speak the question into the microphone so everybody can hear it. Any questions from the import? 1 second, please.
Thank you, and good evening. And thank you very much, doctors, for your presentation. I'm almost 2 years out from my diagnosis. I had a radical prostatectomy, robotic at BAMC. Lately, I've seen a lot of people using the term free PSA, and I have no idea what that means as compared to the PSA test that I had 2 years ago. What can you tell us quickly about that? Thank you.
Eddie, why don't you take that one?
Sure. So free PSA is an enzyme that the prostate secretes both into its ducts, where it becomes part of the ejaculate, and into the blood, where it's measured as a PSA. It is an enzyme that helps the ejaculate to coagulate so that the sperm in it can have time to reach the cervix and swim up and make a baby. In the blood, this molecule, it's an enzyme, is bound, it exists in two states. It's either in a free form where it's floating in the blood like other proteins, or it's bound to a carrier protein like albumin, which is the predominant protein in the blood that binds and carries molecules. For reasons that are not entirely clear, when more of the PSA is bound to a carrier protein like albumin than free, there is an increased risk of prostate cancer. It's sort of, we call it a paraneoplastic phenomenon. That's a fancy word for, it's an association we don't understand. But basically, the less free PSA, so the more of the total PSA for a given PSA that's bound to a carrier molecule, the lower your percent free PSA, you have a greater risk of prostate cancer. It's only used in the index diagnostic setting. It's not approved for screening. It's used in an index diagnostic setting, and a lot of the risk calculators will use it like PCA3, like Dr. Liss mentioned. In the PCPT, there's also a Cleveland Clinic risk stratification model that uses percent free PSA. It's an additional variable that can be used when you're talking to someone about, is it time for a biopsy? That risk-benefit discussion that we talked about being, is it time for a biopsy? It's not useful for following in the settings later.
Thank you, Eddie. The way I think about it is you want to have the lower total PSA and the higher free PSA.
Exactly.
As long as you fall into that category, I think that's where you want to be.
Yeah, and men with an enlarged prostate can have an imbalance of that, so it'll help us. Is it just an enlarged prostate, or is this more of a cancer? And then there's other types. There's pro-PSA, there's all different types of PSAs that are all coming out in new screening tests. There's Prostate Health Index and the 4K score, which are new screening tests. They're trying to hone in on these different types of little PSAs, and can they discern them. So it's an interesting question, and thanks for asking it.
Where are you, Chuck?
I'm here. There's a number of chemistry laboratories that specialize in killing cancer cells. It's like a cottage industry. They will develop new compounds, and then they have a battery of cancer cells. And PC3 is always in the list. The inhibition of growth is measured as compared to the growth inhibition that's caused by one of the other cancer drugs. And invariably, in these articles, there's always one of their compounds which is much better than the standard drugs. There's 5 or 6 of these that I see in the literature every month. And I've been following this for a number of years. I am sad to report that I've never seen any of them developed into therapeutic drugs. Do you have any comment on this?
Vijay, I'm sure that as an oncologist, you have lots of things thrown at you that are going to cure the next prostate cancer. You want to kind of respond to that?
Yeah, so as I understand, there's so much news and articles about how to attack the cancer cell. You know, our cancer cells figure out a way to grow eventually. You know, they're so redundant. When you keep on suppressing them, it figures out to have a resistance mechanism. But if you know, most of the molecules we see out there have to be rigorously tested, and not only in the lab. How the development of any drug, out of 1,000 more compounds, only one comes out to be useful and FDA approved after studying all those things. The success rate is very small. So you have to prove that it's effective in prostate cancer cells in the lab, and then you have to use animal models, mice and monkeys, to see if that works in them. Even then, still, if it works well in them, it doesn't work in humans. Most of them work very well until humans, even until 1,000 patient trial. So I understand the frustration that why can't we get this medication move forward and make a quick assessment and quick approval and help patients. But the process the FDA uses is make sure that there's safety with any of this new compound. The safety is important. Efficacy of the medications we'll see later on, but make sure it's safe to use in humans. So,
like bleach. Great at killing cells, wouldn't want to give it, right? So that's what I try to tell sometimes and that's just one cell. When you look at a prostate, there's so many cells that interact with each other that almost like, let's say, resistant bacteria. So if you have bacteria and you use an antibiotic and you kill all the bacteria, but you didn't kill that one that had the abnormal cells in it, and then that one can grow, right? So it just keeps changing on us. So that's why we get this one, and then either it's too toxic, or it doesn't make it through the clinical trial process, or it's too expensive to make. So these are all things that kind of go into that. So it is complicated.
And we are trying to understand what is driving the cancer. Who is the driver? How does the cell get a message to divide? Instead of just throwing chemotherapy, we now know, okay, the cell prostate cancer uses testosterone to grow. It's the fuel. We blocked it. And the cell says, I'm going to make myself. How to block that? And then once you block all the testosterone, why is the cancer cells still growing? Then where is it getting the message from? What is the genetic or reason for its growth? We are now teasing out those molecules, and genetic mutations say, okay, if you have this driver, use this medication. In future, we'll get there, like as Dr. Liz showed the whole thing. And you will be biopsied and say, your cancer is driven by this right now. Not 4 years ago, right now, it's driven by this molecule or protein. Let's block that.
Thank you. That was excellent. Yes, sir.
Yeah, quick question here. The word by prostate's been going around. Why is the prostate so susceptible in getting cancer?
Wow.
If you can answer that, you win a Nobel Prize.
Anybody want to take a shot at that?
Why is breast cancer so common? It is a gland that, like the breast, which is also a collection of glands, are exquisitely sensitive to hormonal factors that change throughout age. Just like there is an andropause in men, just like there is a somewhat different, but controversially, there's an andropause in men that the hormone axis changes, and these glands, these sex organs that are different in men and women, the reason those organs exist as an embryo is because of the presence of testosterone or the presence of estrogen, to make a uterus. So,
That's right.
These glands are exquisitely sensitive to these growth factors that change throughout life. But the answer is, I don't know.
I think there's two simplified ways. One is genetics. You're prone to certain things. And two, it's connected to the urinary system too. So, diet is important. So everything that you eat or put in your body, or you're exposed to chemicals, those things go into your body, your urinary system, and your prostate sees all that stuff. If it's in the urine, it probably has a way to be exposed to the prostate. So we're finding a little bit more about environmental, what happened where you were working, breathing in chemicals. It all has to go out somewhere, and you pee every day, right? So those are the two things I think that will hone down on it a little bit, if it helps.
Yeah. Like I tell my patient that probably 3 reasons why people get cancers. Genetics you are born with, genetics, diet, environment. In any cancer, these 3, we don't know which one is playing a major role and a minor role, or no role at all. We now know that apart from the genetics, diet is very, very important. We now proved last year that the more number of patients get cancer, 20% of the cancers are caused by obesity. It beat tobacco last year. A number of cancers overweight can cause. So there's some connection between hormonally driven cancers, i.e. breast cancer, prostate cancer, and obesity. So we have to make, diet, there was a big study done using pomegranate juice. They thought that it would reduce the PSA in patients whose PSA is going up. And after diagnosis of prostate, it did not reduce it, but it lowered the curve so that the PSA is not as fast going up. So it's so there's a lot of connections between the diet, our environment, and the genetics we are born with.
Anything else?
Yeah, 13 years ago I was diagnosed with a Gleason 8 and a PSA of 4,400.
Wow.
And at my 7th doctor had the vision to recognize that I had kind of a subset of prostate cancer, which was kind of lymph node specific. And he treated me accordingly, and thank God I'm here. And then did radiation, did a lot of hormonal therapy, still sensitive to hormones, but I did Provenge before I became hormone refractory, and the Provenge seems to have really done a great job for me. And so just thought I'd throw that out there, since you said that Provenge only happens after you're refractory, right?
Before.
Mike, why don't you address the whole idea of, or would you address the whole idea of immunotherapy? I know there's some ideas coming forward that creating the T cells that sensitize tumors to things like radiation or other sorts of agents are kind of a big thing right now.
Sure. So, and you can speak to this as well, but so Provenge is one. So that's one that, men without, symptomatic or metastatic, so exposing your T cells to an antigen and then putting it back in your body to say, okay, go fight. I mean, that's a nice adjunctive treatment that's not chemotherapy that we can use. And now as we go along, there's something called PD-L1 inhibitors. So the T cells, what happens is, as they're fighting the cancer, they just get tired, just like we do. They get tired of fighting. So they get what we call exhausted. So the exhausted T cells kind of don't work as well. So if we give them an immunotherapy type drug, we can kind of revive those T cells and say, okay, get back to work. Start fighting the cancer. And these have been doing very good job in melanoma and in bladder cancer, but they haven't done a great job in prostate cancer. So it hasn't really been approved for prostate cancer yet, but what we're finding out now is that some of the hormone therapy may be blocking its effects. So I'd like to see, and that's what we've been discussing in some of these clinical trials I'm part of, is that should we move this forward before the androgen deprivation? The problem with that is that clinical trials take a long time, they take a lot of money, and if you treat someone really, really early, sometimes it takes 10 or 15 years for us to get the answer. So we need the FDA and to kind of recognize certain endpoints that aren't 15 years away. We need it a little bit sooner. So we're trying to figure out that exactly, but I think that's what you were kind of alluding to. Do you have some experience with that?
So the big field right now in cancer is called immunotherapy. And also there's immunotherapy like how Jimmy Carter got for melanoma. It's approved for bladder, kidney, melanoma, and many other head and neck cancer, lung cancer, and it has not been shown to be efficacious in prostate, but the studies are ongoing. Our body recognizes the cancer does not belong to us. The immune system says, hey, you're not part of this body, you're a little bit different from others. But the cancer keeps sending the signal to fool the immune system. Hey, I'm part of your body, don't kill me. We now know what that message is. So we are blocking the PD-L1 and PD-1. These are the inhibitors where the cancers fool the immune system. Now, instead of finding out what is driving the cancer, why not rev up the immune system to go after the cancer? That's what is called immunotherapy. And there are a lot of vaccine trials going on. Prostvac is another vaccine which has shown a very big help with prostate cancer. The phase 3 trial, the 1,000+ patient trial is ongoing right now, which Prostvac, and watch out for that, and showed a lot of good efficacy in earlier trials, and Provenge is one. I'm doing a trial, there's a vaccine which is made out of your own cells. It comes from Oslo, where we make the vaccine for 10 injections with chemotherapy, chemotherapy with vaccine or without vaccine, and trying to see if we can combine chemo and vaccine makes any difference. So.
Okay, we have an online question. I have been on Lupron for androgen deprivation therapy, ADT, for 2 years now since my salvage high-dose brachytherapy radiation failed to eliminate the recurrent prostate cancer. How long can I reasonably expect the ADT to work before PSA starts to rise and cancer starts to take off?
Eddie, why don't you take that?
Well, that's an excellent question, and the answer is nobody knows. As I mentioned, I've seen patients that have been on ADT alone, single agent, Lupron, Firmagon, for 20 years. They are the minority, but they exist. Then there are people that rapidly progress at 6 months to a year. You're already at 2 years, if I think I remember the question correctly, and that's, I believe, somewhere between 2 and 4 years is the statistical average, but really I think it's weighted a little bit. Most people can reasonably expect between 4 and 6, sometimes even 8 and 10, or not too far out of that bell curve. Again, there's outliers, and everything's a bell curve. There's people that last 20 years, and there's people that don't last 6 months. There's probably biologic differences in those tumors that we don't understand. But the bottom line is we don't know yet why some people essentially, for lack of a better word, have a de facto cure with, I use that term sparingly because they essentially last long enough to die of something else. And others, don't. But the majority of people are in that bigger bell curve of somewhere between 2 and 6 years. But again, a lot of people I've seen 8 to 10, and a fair number of people I've seen shorter than that.
I showed the side effects of androgen deprivation therapy or hormone therapy, right? So there was a trial to say, I know how long should we know, as like Morales said, we don't know why some patients the PSA goes down to 0 after using Lupron, and some it doesn't go down, it comes a little bit down and then stays there. But there was a trial done, can we spare patients of side effects of Lupron for longer term? So they took 1,000 patients and divided them in, one of the groups got continuous Lupron, no stop, forever until the cancer figures out a way to grow. In others, they did intermittent, on and off, used it until the PSA gets to the lowest level, get them off, and then once the PSA rises, use the Lupron again. The rationale was to see if the side effects can be, is it better or not? And that study has shown, you can probably talk about the intermittent versus
you're doing a good job.
So basically, it did not show a major difference even if you stop and go approach. Okay, in some subset of patients, it was a different result, low volume versus high volume. But I have started doing this intermittent therapy in quite a few patients to spare them from long-term side effects of testosterone depletion. So.
Yeah, and in that study, the 2 outliers were in the men who had it continuously, there was a little bit effect of dementia. So we're actually investigating that to see if you can predict the men who may be at risk for cognitive changes or thought changes and dementia, and then maybe those are the people that really need the intermittent. And on the intermittent side, where you stop and use it, they had a little bit more cardiovascular issues. So if you're someone who already has heart disease, maybe you should just do the continuous. So there is some subtleties in that trial that we're still trying to figure out. But that is a good way for some men who have been on it for a long time that say, hey, let's take a break for a little while, see what happens to the PSA. It's a completely reasonable thing to do.
I use intermittent therapy quite a bit, and I try to gauge it and kind of nuance it to where I have these guys off the drug during the summer. God knows in San Antonio it's hot enough you get another hot flash. So you really can keep people considerably more comfortable if you take those kind of things into consideration. Anything else? Do you want to get some more questions online?
There's a lot of excitement around personalized medicine, and if the doctors could talk a little bit about the opportunities around genomic testing in addition to sequencing and combinations of therapies.
Mike, why don't you take the genomic testing?
Sure. So I alluded to some of these things, and I didn't really want to point out specific tests here because, like I said, there's kind of different indications for when or when not to use those. Some of the tests are quite expensive, so sometimes we have a discussion about, is it going to change my management? Is the information that I'm going to get from this genetic test going to change what we do? I'm not going to get it just to get it, right? So that's the conversation to have, is if I get the genetic test, what are we going to do next? And if it's the same, then I don't think you should get it. And if it is different, like, well, there's a XYZ and this would be the plan, okay, then that makes sense to get it. More and more insurance companies are recognizing this as options, so I do think that it's getting better. And like I said, right now we don't know if some of the testing will lead to better outcomes. So they still need to be tested in trials. So personalized medicine, that's what we all want. We want, what's the drug to use for my cancer that my body will do well with. So the other issue is that some people have side effects to certain medications, or their liver won't process the medication like someone else's will. So there's a lot of subtleties coming into this. So it's really early, but like I showed the pinwheel, we are getting to that point. We are starting to see what is that tumor doing, why is it evading certain systems, and then can we attack that. But that each of those pinwheels need its own clinical trial. So we need to test it against placebo to make sure it works before we just start giving drugs to people and we don't know. So we have to test them, number one, to make sure they're safe, and two, to make sure it's actually working, so we can forget that one and go on to the next one.
If you think about really what we do for cancer and prostate cancer, it's really rather crude. I cut it out, and you take the entire organ, and if it comes back, or if you choose, I hit it with a hammer of various kinds, either composed of X-rays or protons or poisons that affect the entire body. It's really quite exciting that they are personalized medicine, that maybe, such really truly crude ideas in how we treat a disease that's, a microscopic collection of our disorganized body. It's truly an amazing and exciting time.
Vijay, would you address the sequencing part of that question?
Sure. So now the new buzzword is the next generation sequencing of your cancer. Find out the mutations, what is driving the cancer, and we can do it on the tumor, or we can even do it on the blood, because the cancer releases the DNA into the bloodstream. We can measure that, we can find out what type of DNA it is and what protein, and we can target that. We know what drives the cancer, but we don't have medications to counter that mutations. I do blood tests now. It's a new blood test where we take a sample of blood and we can find out if you have prostate cancer, what is the tumor mutation burden? We call it TMB. What is the percentage of high TMB means aggressive cancer, too much cancer. Low TMB means tumor mutation burden, less cancer. We are not there yet to show the differences, how these all pan out. But the field is moving too fast with sequencing. In future, we can take a normal patient, healthy patient, before it shows up in the prostate or before it shows up elsewhere, we can find it in the bloodstream. We are doing a 50,000 patient trial. How did we find the trial? We are taking mother's blood to find fetal abnormalities. Mother's blood instead of taking the amniotic fluid. Once we take the blood of mothers, we found cancer DNA in some women. And they followed those women, all of them had cancers, 5 years down, 10 years down. So we are trying to take the blood sample and see if anybody has cancer DNA. We're not there, there's no commercialized test yet. That's in healthy patients. In cancer patients, we employ sequencing, genetic sequencing to find what drugs can be used the best.
pretty exciting times right now, and it's just moving so rapidly. Hard to keep up with, but it is exciting. What else you got there for us, Chuck?
Well, the whole idea of informed decision making really rests on understanding what the new advancements are that are coming down the pike, and we talked a little bit about this already, but that information and the new advancements really provide substantial hope that's grounded in facts and advancements. So if each of the doctors could still talk a little bit more about what's happening now that and what's coming down the pike, that provides that information that really substantiates hope for fighting this disease effectively.
As one of the things that Dr. Liss talked about and is very exciting, something that we've known in kidney cancer for a long time, is that the global burden of cancer, like the physical amount, can have a profound effect on how, effective the therapy you're giving works. Meaning, if you give a medicine or you do a treatment that kills 95% of cells, if the overall burden is low, then that proportion of cells that is left, we think might have a greater chance of being mopped up by the immune system or dying on their own because cancer cells are inherently unstable. So one of the things that's very exciting for me as a surgeon is the new field of cytoreduction, the fact that people may do better even if you have limited, what is called oligometastatic. Oligo is Greek for some, so not a lot. So doing surgery still on those patients, for instance, patients that present to me with nodal disease in the pelvis, that which I would excise. Those are still potentially, and there's now retrospective series, no one has done this prospectively. Retrospectively, those people have done well, and there's even been cures with patients that have disease already in the lymph nodes. It's an exciting time as a surgeon, so that's what I'm looking forward to, and hopefully getting prospective trials of cytoreduction moving forward.
A big thing for me is how can I decrease the side effects of all these medications and make the patient live longer. I think we are getting there. If you look at what happened in the last 10 to 15 years in prostate cancer, we have a lot of new medications. Every medication is very expensive, and how to reduce the cost, how to improve the quality of life of patients, and how to get new medications we can try through clinical trials. Example is the sequencing, the genetic sequencing we do on cancers, like what's BRCA, 1 to 2%? Mm-hmm. 2% of the patients have BRCA mutation. If I know that the patient has BRCA mutation, 2% of 40 to 50,000 patients who die of prostate cancer. Still, I can make a huge difference in some patients. So we have to go with baby steps, categorize the cancers into various buckets. This subset needs to be treated this way. This subset needs to be treated this way. That's going to be the next big field. So,
I think for me, the best slide that you showed was the multidisciplinary stuff. I think that's probably been the biggest change in the last 10 years is, okay, when somebody gets diagnosed, they need a team. You need a team of people. And now we're starting to add geneticists, genetic counselors, even laboratory people if we're doing clinical trials. So you have a huge team now. Maybe you need both surgery and radiation for really aggressive early detection. If you showed up with metastatic disease, okay, maybe that's the time to do the sequencing before you get androgen deprivation, and then do it when it recurs to see what the changes are. So I think that's probably the biggest, most immediate change that people are seeing, is that now everybody's starting to talk to each other, and it's becoming a team science.
Very good. Chuck?
Well, I think that's about all the time we have for questions. We're coming up on 7:30. So I just wanted to, on behalf of the US2 staff and the board of directors, I wanted to thank everyone for being here in person. Thank everybody who's joined us online. Thank all our sponsors, Bayer, Dendreon, Janssen Oncology, and Los Padres. Dr. Reyna, thanks so much for moderating. Thank you for our panelists, Drs. Morales, Dr. Gunuganti, and Dr. Liss, and the support group leader, Johnny Staha, along with Don Triplett, and area support group leaders Janet Shady and Joe Harrison. And thank all of you so much and for being here. And Bob Wright, you also, thanks so much. We appreciate everyone being here. So good night and take care.